In this video, I will explain the nature of pain and also how EMDR therapy can be used to reduce the experience of pain that people have, but also possibly eliminate totally phantom limb pain. Please join me. Welcome, I'm Dr. Michael Paterson, clinical psychologist and EMDR Europe Accredited Senior Trainer. I would like to help you improve your practice of EMDR therapy. In this video, I will be explaining about the nature of pain and how EMDR therapy can be used effectively in treating that. I will of course tell you how to do it. During the video, if you like what you hear, please click like down below. You could even subscribe to the channel if you haven't done so already. Of course, it is free. Pain has a number of different dimensions. Going back to the 1960s, Melzack and Wall had identified pain as having 4 particular dimensions, and they developed the McGill Pain Questionnaire. The dimensions are a sensory dimension, damage to the body itself; an evaluative dimension, the meaning it has for the individual; an affective dimension, the emotional component; and also a miscellaneous dimension, a catch-all category for anything the other dimensions didn't pick up. The McGill Pain Questionnaire is still in use today. There is a short form which is specifically a sensory dimension and an affective dimension. That way it can indicate the severity, intensity of the pain that somebody is experiencing. Because pain has a number of different dimensions, EMDR therapy can be used effectively to change our perception of the pain. It will impact on the evaluative dimension, the meaning it has for us, but also the affective dimension, that emotional component. Melzack and Wall developed initially what was called the gate control theory of pain. This was a very ingenious, groundbreaking way of thinking about it. If you look at this picture, imagine this gate to the field. If it is wide open, 4 cows at a time can go through. Close it halfway over, 2 cows at a time will go through. Close it a quarter way, 1 cow at a time will go through. Close it completely, no cows will go through. So Melzack and Wall were saying in those days that our perception of pain can be influenced by other factors. And we can, in the preparation phase with EMDR, alter how people perceive their pain. And by processing with EMDR therapy, then that also helps them have a different perception of it. The gate control theory evolved into the neuromatrix theory of pain. This was around 1999 to 2000. Melzack published a paper in 1999 called From the Gate to the Neuromatrix. And it talks about then patterns of neurons firing in a certain way, but also the involvement of the neuroendocrine system to affect our perception of pain. But I think the gate control theory is a good way of thinking about it. It helps us think of that in images. When I'm working with somebody who is suffering from chronic pain, EMDR therapy can be used to change the perception of their pain. For example, if they had a pain at an intensity of say 8 out of 10, by processing that with EMDR therapy, that intensity might come down to a 3 out of 10. I'm sure you will agree that that can make a significant difference in somebody's life. Because it goes down to a 3, it may not go any further. Why then would it not go any further? Remember, there is a sensory dimension to pain. That means that the damage to the body itself will create pain in its own right. However, when we are working with phantom limb pain, there is the potential for that phantom limb pain to totally disappear altogether. The thing to remember is that with phantom limb pain, pain is being experienced in a limb that is no longer there. In terms of the adaptive information processing model, the AIP model as you would know it, then that holds that the experience of the pain, that pain that's locked in, stored in a memory network, stored dysfunctionally, just as a traumatic memory can be. Interestingly too, the thalamus and the amygdala two structures in the brain in the limbic system which are responsible for our perception of psychological trauma and our reaction to it are also heavily involved in our perception of pain. Let's move on to consider how we work with somebody suffering from chronic pain. I worked 1 day a week at a pain clinic at a general hospital quite close to Belfast in Northern Ireland where I live. I developed a lot of experience in working with these patients and seeing them presenting in different ways with different traumas. Taking the client's history, we do that as normal, identifying experiences that the client has had in their lives, good or bad. I ask also, what makes your pain worse? That helps me identify triggers that there are that make the pain worse for the client. Also, I ask the client what makes the pain less uncomfortable or less intense. These are resources. It's easy to identify those in the history taking. In the preparation phase, I educate the client about psychological trauma and also the nature of pain and how they can change their perception of it. I teach the client methods of self-soothing, such as the calm safe place. Also, the light stream can be very effective. It can be targeted to the site of the pain and actually change how the client perceives it at that time. It can help ease it and soothe it. The important thing is by calming the client's body, then the pain will get easier. The thing to remember is that muscles pull, they don't push. If the client feels pain, they will often tense up. It will make the pain worse. So if their body is relaxed, then the pain is easier. I help the client identify targets for processing. The past events, the traumatic events in the client's life. You will, of course, know that when these traumatic memories are activated, big T or small t trauma, the amygdala responds and we tense up. We go into a state of increased arousal. Some clients might dissociate, which will help them manage their pain as well, but still, ultimately, it's not a good way to be. By identifying these past events, these are targets for processing, as is the pain experience itself. Once I have identified the targets for processing, those past events, big T and small t traumas, then they can be processed. I would tend to process those first before focusing on the pain experience. When it comes to processing the pain experience itself, I invite the client in the assessment phase to bring up a picture in their mind of what the pain is like for them. So I ask them to picture yourself with your pain. In fact, sometimes it is a good idea to invite the client to draw a picture of how you see yourself with your pain, like in this next slide. Once I have that picture, the client has it in front of them, they're looking at it, and I ask, as you look at that picture, what words best go with it which describe a negative belief you're having about yourself now? What would you prefer to believe about yourself now? And how true does that positive belief feel to you at this moment on a scale of 1 to 7, 1 being completely false and 7 being completely true? So far, this will sound very familiar to you, I'm sure. So then I ask the client, bringing up that picture, noticing it in front of you, and those negative words, hold them together. What emotion are you noticing now? And how intense is the pain for you at this moment? 0 is no pain at all. 10 is the worst pain you could possibly imagine. And where do you feel it in your body? I'm sure you noticed that is very similar to the standard assessment phase that you're well used to. We have a picture that the client can work with. There is a negative cognition, a positive cognition, and a VOC. So that negative cognition is the meaning the pain has for the individual. The emotion is the emotional component, that affective dimension. And then, of course, how intense is it for you now? 0 to 10. That's the sensory dimension, mixed together with the other two. We say to the client, bring up that picture, repeating those negative words to yourself and noticing that feeling in your body. Go with that. We add in a set of bilateral stimulation. Have a breath, and what do you notice now? We go with whatever the client reports. We continue the processing from time to time, coming back to target. Just thinking about yourself with your pain now, what do you get? We continue processing until that intensity goes down to as far as it's going to go for that particular client. Remember what I said earlier. When we're working on chronic pain, it does have a sensory dimension. So I wouldn't necessarily expect that SUD to go down to 0. If it does, that's fine. If you're working with phantom limb pain, after having processed the past events, then you can ask the client to focus in on their perception of themselves with their pain. That might go down to 0. You could then invite the client to draw a picture of how you see yourself with your pain now, and I can guarantee you will see a significant difference. You will move on after those past events and focusing in on the pain experience to work on any remaining present triggers, and then of course the future template. I hope this video has been of value to you. If it has, please subscribe to the channel down below. It's free. And also please click like down below if you haven't already done so. I want to help you become the best that you can possibly be in delivering EMDR therapy. By doing that, you and I together can make a big difference in the world. Thanks for watching.